So I think we don't know yet. It starts by not knowing exactly who definitely benefits from targeting agents from the get-go. There's certainly data now that is phase 2 data for CDK4/6 inhibition in first line, and obviously that's an attractive target because the preliminary results shows that the progression-free survival with that combination is actually quite impressive. The problem is that the phase 3 data, despite having accrued other patients, does not have yet complete mature results, and therefore it's hard to know if this combination actually will yield overall survival advantage or not. Having said that, it is hard to see overall survival advantage in ER-positive cancers, and therefore I think, considering the data we have, it is obviously an attractive strategy to start with CDK4/6 inhibition in addition to endocrine therapy from the get-go, but perhaps this is not a strategy that is interesting for all patients. To give a rough example, if somebody who is maybe not in that great performance status or for other medical conditions and has minimal breast cancer burden of disease and feels really well and wants to have a really good quality of life, maybe that patient is not appropriate to start with that, and maybe that patient will do well with endocrine therapy by itself. And in view of results of, let's say, PALOMA-3, which looked at CDK4/6 inhibition in second line and above, that is also a positive study, and that with phase 3 data, we know that that's a fallback if that patient doesn't, stay on endocrine therapy by itself for a very long time. So I think in the big scheme of things, the data we have right now suggests that we can either do endocrine therapy by itself or combine a CDK4/6 inhibitor in first line. At progression, patients could get endocrine therapy by itself or get a combination, let's say, of endocrine therapy and an mTOR inhibitor, where there is progression-free survival advantage, again, despite negative overall survival data. But we do have lots of options, and ultimately what we'll have to prove in clinical trials is if combining two different pathway inhibitions would do a better job than each one of them alone, and again, figured out how to best sequence that. I don't think we have the answer to this, so a lot of it will be patient preference, physician preference, and a judgment call.